Okay, so again, we went over diastolic function, and at this time, everybody should be able to recite what what are the parameters of diastolic function. When we talk about diastolic function, what are we really saying? What are we looking at? Again, remember when we say diastole, that's when the heart fills with blood. The heart starts to fill with blood when the aortic valve close. The same thing occurs on the right side. When the aortic valve close, mitral valve is still closed, so you have your IVRT. Then the mitral valve opens. You have suction of blood from the left atrium across the mitral valve. You get your so-called E velocity. Then you have rapid equalization of pressure between the left atrium and left ventricle. You have your diastasis. Then the atrium contracts and you get your A velocity. So those are the mitral inflow parameters that determines the diastolic function. And we can look at other things such as the mitral annular velocity, tissue Doppler uh, imaging, or tissue Doppler velocities. And we talk about the base of the heart when the heart contracts. The base of the heart. And once at the base of the heart, that's where the mitral valve inserts into the heart. So that's the base, and the base moves up towards the apex in systole, and then in diastole it moves downwards. So if we're talking about diastole, we're talking about the two diastolic component, your E prime and your A prime. We're more interested in the E prime. Okay. Other things that we're going to look at is your left atrial volume and your left atrial pressure. So those are the things that are going to determine diastolic function and hence dysfunction. Okay, so when we talk about diastolic dysfunction, diastolic dysfunction is very important, extremely important, because of this statement. Diastolic heart failure, when some, when they say this patient is in heart failure, approximately 50% of all heart failure patients have diastolic dysfunction. So half of all your patients who are in heart failure gonna have diastolic dysfunction. We know when the patient has systolic dysfunction, we check the ejection fraction. The ejection fraction is usually less than 40%. So we know that. That's not a problem. We just check the ejection fraction. And if the patient has signs and symptoms of heart failure, then that is the current term is heart failure with reduced ejection fraction. So if the patient have heart failure and the ejection fraction is not normal, the ejection fraction is not abnormal, then we call that heart failure with preserved ejection fraction. So once the EF, ejection fraction that is greater than 40%, if the patient has signs and symptoms of heart failure, we call that heart failure with reduced ejection fraction. We're not dealing with that today. We're talking about heart failure with preserved ejection fraction. So when you do your ejection fraction, it's above 40%. When you do your diastolic parameters, they're abnormal. Okay, so the reason why we spend time looking for diastolic dysfunction is because half of all our patients who have heart failure because there's a problem with with diastole. All right. A long time ago, we had 4 grading system that made it simpler, easier. So we only have 3 grading system. Okay, we have grade 1, grade 2, and grade 3. So we have three levels of severity of diastolic function. And just like in any other staging system, the higher the number, the worse the disease is. Okay? So you go from grade 1, which is not too bad, to grade 3, which is bad. So we're going to make it simple. Okay? We can present it very complicated, but we're going to make it simple. And if we're going to evaluate a patient, we're doing an echo and we're going to evaluate the grade of diastolic dysfunction. There are 5 things you need to look at. Okay? And if those 5 things don't help you, then there are additional things that you can use. But when you see the patient in the echo lab and you're doing your assessment, look at these 5 parameters first. Okay? The first thing you're going to look at is your E to A ratio. All right. So again, remember when you do your mitral inflow, okay, so you may see something looking like, so you may have a small e, okay, and a big A, okay. So this is one scenario. So this is our E velocity, and this is our A velocity. So you want to look at your mitral inflow at your so-called E to A ratio. The next thing you're going to look at is your E prime ratio. So remember, to get your E prime, you have to do your mitral annular velocity, your tissue Doppler imaging, and you're going to look at E prime. Okay? So you want to know what that ratio is. Okay? So your E prime ratio, and we're going to delve a little bit more in this. You can look at so when you look at the mitral annulus, you can look at the medial mitral annulus or the lateral mitral annulus, and you'll have a velocity for the medial and the lateral. And you can also get an average. So you can add your medial to the lateral and then divide it by 2, so you have an average E prime. But it's customary for us to use the medial E prime ratio. So you get your mitral E, you get your E prime from your tissue Doppler, and you get that ratio, okay? So the next thing you're going to look at is your tricuspid velocity, TR velocity, okay? TR velocity, all right? And the last thing you're going to look at is your left atrial volume, okay? So in about 90% of the cases, just by looking at your prime ratio, sorry, your E to A ratio, prime ratio, TR velocity, and left atrial volume, you can determine the grade of the diastolic dysfunction. As we mentioned before, there's just 3 grades: grade 1, grade 2, and grade 3. Patients with grade 1 diastolic dysfunction, they are less severe. Okay, when you have grade 1 diastolic dysfunction, you have a problem with relaxation. As the diastolic dysfunction gets worse, you move from abnormal relaxation to where the heart is stiff. You have a problem with compliance. So initially, the heart doesn't relax properly, okay? And when you look at your E to A, the E is going to be smaller than the A. Your EE prime ratio is going to be less than 15 medial EE prime ratio, okay? So that 15 is a very important number, okay? If the EE prime ratio is greater than 15, it is telling you that the left atrial pressure is high, okay? Usually when you have grade 1 diastolic dysfunction, your left atrial pressure is not high. It's not high, okay? So your grade 1 diastolic dysfunction patient, the E is going to be smaller than the A. Your EE prime ratio, and let's just use medial for the time being. Your EE prime ratio is going to be less than 15. As a matter of fact, it may be less than 10. Your TR velocity, the magic number is 2.8 meters per second. Your TR velocity is going to be less than 2.8 meters per second. And your left atrial volume, and when we talk about left atrial volume, we really want you guys to use the left atrial volume index. Left atrial volume index. And so you do your left atrium and you divide it by the body surface area, and that's how you index anything in medicine. You divide the whatever, it's a volume, whatever, by the body surface area. And the magic number is 34. So if it's less than 34 mLs per meter squared, then the left atrial volume is not enlarged. Okay? So again, the 4 things you're going to look at to determine the severity of the diastolic dysfunction, or to grade the diastolic dysfunction: your E to A ratio, EE prime ratio, and let's for simplicity, let's just use the medial EE prime ratio, your TR velocity, and your left atrial volume index. Your grade 1 diastolic dysfunction patient is going to have a small e and a relatively big A, so the E is going to be smaller than the A. Your EE prime ratio is going to be less than 15, more likely it will be less than 10, because these patients are the earliest stage of the diastolic dysfunction. So the left atrial pressure is usually not elevated. EE prime ratio, if it's greater than 15, is telling you that left atrial pressure is elevated. Your TR velocity. So if you think about it, it makes a lot of sense. You know, the first abnormality is a problem with relaxation. So you have not built up tremendous pressure in the left atrium. We talk about the left ventricle filling pressures, okay? Because it's an early form of dysfunction. So the pressure in the left ventricle filling pressure is not very high. Okay, so if it's not very high, then you're not going to have a lot of back pressure. So therefore, if the left atrial pressure is not very high, it's not going to dilate the left atrium. So the left atrium is not going to be big, and you're not going to get a lot of backflow of blood to give you any tricuspid regurgitation. So with your grade 1 diastolic dysfunction, okay, where the patient have a problem with relaxation. So we usually say it's a grade 1 diastolic dysfunction is abnormal relaxation. The E smaller than the A, EE prime is less than 15, usually less than 10. TR velocity less than 2.8 meters per second. Your left atrial volume index is usually less than 34 mLs per meter square. And if you don't do the left atrial volume and index it, then you can just look at the size. If you do a linear measurement, you can have an idea if it's enlarged. But you should practice to do the left atrial volume, and we'll go over how you do that again. Okay. So abnormal relaxation, grade 1 diastolic dysfunction. We're going to move on to grade 3 because it's easier to understand grade 3 than grade 2, and then we'll go back to grade 2. So if the patient has grade 3 diastolic dysfunction, these patients are very easy to recognize. Okay, so this is the worst stage of the diastolic dysfunction. When you look at your E, you have a big E. Okay, you have a big E and a relatively small A. Okay, so this is your E and this is your A. The first thing that jumps out to you is when you do your E to A ratio, it's usually greater than 2. Once your E to A ratio is greater than 2, you essentially don't need anything else because that clinches the diagnosis of grade 3. So your E to A ratio is greater than 2. So this clinches the diagnosis of grade 3 diastolic dysfunction. Okay, so again, this is the worst stage of diastolic dysfunction. These patients are usually sick, and a lot of these patients will have very depressed LV systolic function. Okay, they also, the thing about it, when you have LV systolic dysfunction, you invariably have diastolic dysfunction. So the ejection fraction may be 20%. You do your E to A ratio and it's greater than 2. If you do your E prime, remember E prime greater than 15 suggests elevated left atrial filling pressures. And in these patients, your E prime ratio is greater than 15. So your E prime ratio is greater than 15. When you do your TR velocity, okay, your peak TR velocity is greater than 2.8 meters per second. Okay. When you do your left atrial volume index, that is greater than 34 mLs per meter squared. Okay. Relatively easy to identify these patients. Okay, be careful. 16-year-old patient who comes to the lab and have no symptoms and nothing at all, they're gonna have a E2A ratio greater than 2. Okay, because young patients will have big E's and small A's. Their heart is not sick. So it's different if someone, above 30 coming to the lab, especially if they have symptoms, if they have shortness of breath, leg edema, and you do your Doppler studies, your E2A is greater than 2, EE prime greater than 15, TR velocity greater than 2.8, LA volume greater than 34 mLs per meter squared. This is your grade 3 diastolic dysfunction. These are very sick patients. They have a problem with compliance. The heart is now stiff. Okay? Your grade 1 diastolic dysfunction patient, their problem is a problem with relaxation. Okay? So your grade 1, these patients have a problem with relaxation. Your grade 3 patients, they have a problem with compliance. Okay, the heart is non-compliant, stiff. So this is grade 3. Okay, remember, your grade 1 patients are not very sick. It's the earliest stage of diastolic dysfunction. Your grade 3 patients are very sick. Okay, and the numbers will reflect that. Now we come to the grade 2 patients, and sometimes the grade 2 patients can be a little tricky, but if you apply, so grade 2, if you apply the parameters with some basic understanding, you can tease out the grade 2. The easy grade 2 is the patient who have what we call pseudonormal, your so-called pseudonormal. So if we say it's pseudonormal, then they're going to look pretty much like they're normal. So the E is going to be bigger than the A. But of course, it's not going to reach, the E to A ratio is not going to be greater than 2. So the E is going to be bigger than the A, but less than 2. That the ratio is going to be less than 2. So it looks normal, but these patients are very sick. Okay? They're sicker than your grade 1 patients, because when you have grade 2 diastolic dysfunction, you usually have evidence of increased left atrial pressure, increased left atrial volume, and your TR velocity is going to be greater than 2.8, suggests that you have some amount of pulmonary hypertension. So the classic grade 2 diastolic dysfunction patient, the E is bigger than the A, so we call them pseudonormal because they look normal, but when you do further analysis, the E prime ratio is going to be greater than 15. Okay, so the EE prime ratio greater than 15, and we're using the medial E prime. Okay, again, EE prime ratio greater than 15, telling you that the left ventricular filling pressure or the left atrial pressure is elevated. When you look at the left atrial volume, that's also going to be increased. So the left atrial volume is going to be greater than 34 mLs per meter squared. Okay. When you look at your TR velocity, that's going to be greater than 2.8 meters per second. So this is your grade 2 patients. Sometimes the patients don't fall into these nice little boxes, and that is when you have to use other assessment to determine the grading of the diastolic dysfunction. Again, you're only going to look at 4 things initially. You're going to look at your E to A ratio. You're going to look at your EE prime ratio, TR velocity, and left atrial volume index. Your grade 1 diastolic dysfunction, small e, big A, EE prime ratio less than 15, TR velocity less than 2.8 meters per second, left atrial volume less than 34 mLs per meter squared. Grade 1. Grade 3, easy. E to A ratio is greater than 2. EE prime ratio greater than 15, TR velocity greater than 2.8, left atrial volume index greater than 34. Your grade 2 is your so-called pseudonormal. Okay, the E is bigger than the A, but it's not, the ratio is not greater than 2. And then you have other evidence of increased left atrial volume and pressure. Okay, left atrial volume greater than 34 mLs per meter squared, TR velocity greater than 2.8 meters per second, EE prime ratio greater than 50. So this is an easy way to grade diastolic dysfunction. Okay, again, 50% of your heart failure patients have diastolic dysfunction. Okay, they have what we call diastolic heart failure. So thinking a few years ago is that once the patients have heart failure, they have a problem with systolic function. That's not the case. It's usually, a little old lady, you know, who develop heart failure, skinny, and come to the hospital. You do her echo, her heart is banging away, and you say, well, everything looks good. But you need to do further analysis, and you'll find that she may be grade 2 or grade 3 diastolic dysfunction. Okay? Again, the higher the grade, it suggests worsening of the left atrial pressure and left atrial volume. Okay, so you have to do these analyses. All right, so let's go through the lecture. All right, so again, if the patient have a normal LV ejection fraction, you have to take a lot of things into consideration. You have to take the age of the patient. Again, remember, it's the 16-year-old patient who is coming to the echo lab because his pediatrician heard a murmur. His E to A ratio is going to be greater than 2. But when you look at his EE prime, it's going to be much, much less than 15. Left atrial volume index is going to be very, very small. Your TR velocity going to be negligible. Okay, so it's different than if you see a patient who is age 60, and if that patient have a E to A ratio which is greater than 2, you're almost certain that he's going to have grade 3 diastolic dysfunction. All right. what I'm going to do, I'm going to switch to the current uh, guidelines, and we're going to sort of just run through these because I gave you the background information. So with a normal ejection fraction, you should take the age of the patient into account. Uh, in your healthy sedentary elderly patient, um, okay, diastolic dysfunction, as we said before, appears to be a problem with increased LV stiffness. Okay, and when you look at your E prime, this is supposed to be E prime. So what we're saying is that in some of the older patients, you have to be careful. So you have to look at the age of the patient when you're evaluating the patient for diastolic dysfunction, because your 80-year-old patient, because of age, the LV is going to be stiff. Okay, but when you look at your EE prime ratio, it's not going to be elevated. Okay, and when you look at other parameters for diastolic dysfunction, they're going to be normal. So they may have, they may have a small e and a big A, but when you do your other evaluation for diastolic dysfunction, it's not there. Okay. Now, what I should have mentioned to you is that so your grade 1 diastolic dysfunction is simple: small e, big A, left atrial volume index is normal, TR velocity is normal, EE prime ratio is normal. So that patient is okay. With your grade 2 diastolic dysfunction, you need to have at least 3 parameters suggesting that the left atrial pressure is elevated. So again, evidence of left atrial pressure elevation is your EE prime. So EE prime and medial greater than 15, TR velocity greater than 2.8, and your left atrial volume index greater than 34. So those are things that tell you that your left atrial pressure is elevated. All right, so it's a typical patient, and this is your mitral inflow, and you see your E is bigger than the A, and this could be normal. This could be perfectly normal. All right, if they don't give you the age of the patient, it could be perfectly normal. If it's a 16-year-old, then it's normal. If this patient is 60, it's probably not normal. As a matter of fact, it's not normal if they're 60. However, when you look at your tissue Doppler now, your tissue Doppler is going to give you more information. Okay? Again, you put your cursor on the mitral annulus, and you can put it to either the medial mitral annulus or the lateral mitral annulus. Your S prime is when the base of the heart moves up towards the apex. You get your so-called S prime. And then in diastole, the base of the heart moves downwards. You have 2 diastolic components. The early we call E prime, the late we call A prime. And you can see the velocity at the side. This is huge. So these two parameters taken together, this is a normal patient. Okay? This is a normal patient. E bigger than the A, your E prime is huge. Okay? This is just a normal patient. All right? So another thing that you can do is you can use the Valsalva maneuver to help to distinguish your pseudo-normal filling from from a normal patient. Okay, so if you have a pseudo-normal and you tell the patient to Valsalva, that will automatically change into a an abnormal pattern. It will look like your grade where you get a small E and a big A. Okay. Um, okay. You can use as again we said you're gonna keep it simple. Okay. There's a lot of complex things you can do, but you're keeping it simple because you need to make the diagnosis. All right. Um, so these are mitral annular velocities, and you 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 have to try and do the mitral annular velocity properly. Okay, and these are four scenarios, uh, and we're looking at the medial or the septal mitral annular velocity. In frame A, the Doppler settings and volume location are optimal. Okay, so in A, your settings are optimal. So let's go through what we are having, what we see here. So this is your tissue Doppler imaging. The cursor is at the medial mitral annulus, and you press the TDI button. So this first deflection here, your ECG is on top. Okay, again, this first deflection is what we call your IVCT, isovolumic contraction time. And then the second upward deflection is your S prime, because the base of the heart is going to move towards the apex. Your transducer, sorry, your probe, yeah, your probe is right there. If the base of the heart moves up towards the transducer, then your recording is going to be above the baseline. So your S prime is above the baseline. Then in diastole, the base of the heart moves away from the apex. It moves away from the transducer. So you get downward deflection. This first downward deflection is your IVRT, and this is your E prime, and then this is your A prime. So don't be fooled and calling this your E prime and your A prime. The first one is your IVRT. This is the E prime. This is the A prime. Okay? So another mistake some people make is by putting the cursor on the ventricular septum. Okay? So you see you can change the velocity because we're not looking at the ventricular sept. We don't want the ventricular septal velocity. We want the mitral annular velocity. Okay? And you can see how the velocity change. Okay? You get much larger velocities. So you're not, you won't be able to make the correct assessment. All right? All right. Uh, in C, the gain is very low. Okay? So, and then in D, I again. So you have to do a proper study. Okay? You have to make sure that your sample volume is at the mitral annulus. Okay? And make sure your gain settings are adequate. All right. So again, if you get a pseudo-normal pattern, so you see this looks normal, but if you know the patient is age 60 and you tell them to Valsalva, you automatically change into abnormal relaxation pattern. Okay. So one of the first things you can do when you see a pseudo-normal, just ask them to Valsalva. All right. Again, your pulmonary arterial systolic pressure It's important. We use the TR velocity as a surrogate. All right. So the worse the diastolic dysfunction, the greater the TR velocity. Okay. Your pulmonary pressure is gonna be increased. So, and then left atrial volume. The bigger the left atrial volume, usually the worse the stage of diastolic dysfunction. Okay. Of course, you have to make sure there's nothing else causing left atrial volume dilatation. Make sure there's no mitral stenosis, no significant mitral regurgitation. Okay. All right. So if this is your mitral inflow, so you get a big E and a small a. So this could be normal or it could be pseudo-normal. But if you look at your pulmonary vein flow, and if you have a very small systolic component to a diastolic component, this is probably abnormal. Okay, so this is probably a pseudo-normal. So you can use the pulmonary vein flow to confirm your suspicion. Okay. Um, So again, if you do your mitral inflow and you see a little hump in between your E and your A, this is what we call an L wave. And an L wave suggests there's increased LV filling pressures. That's what that means. There's an increase in LV filling pressures. Okay. Again, you get the L wave. Okay. So suggests increased filling pressures. And sometimes you can get it in your tissue Doppler assessment as well. You get a little L wave right there. All right. So again, we keep it simple. With your grade 1 diastolic dysfunction, your E prime usually is less than less than 7 centimeters per second. Okay, your E prime is usually less than 7 centimeters per second. Okay, you can use the lateral or the average, keep it simple. Just use if you're going to use the medial, less than 7 centimeters per second. For the lateral, less than 10. Remember, the lateral E prime is usually larger than your medial. Okay, for grade 2, your left atrial maximum volume index is greater than 34 mLs per meter squared, and your TR velocity is greater than 2.8. Okay, so this would be your grade grade 2. Okay, all right. So again, the things that you're going to look at, the variables, is you're going to look at your mitral inflow velocities. You're going to look at your E to A ratio. You're going to look at your EE prime ratio, the peak TR velocity, and the left atrial volume index. Okay. Other things that can help you is your pulmonary vein flow, or you can look at the global LV strain by speckle tracking echo. Very important. If your patient has moderate or severe mitral annular calcification, if your patient have more than moderate mitral stenosis, more than moderate mitral regurgitation, you cannot use your E prime. Also, if they have mitral valve repair, prosthetic mitral valve, LV assist device, you have left bundle branch block, or pacemakers, you cannot use your E prime, okay, and atrial fibrillation. So you have to use other parameters to look for left atrial uh, increase in left atrial pressure. Okay. All right. So again, your grade 1 is a problem with relaxation. They have abnormal relaxation. They have a small, relatively small E, a big A. The E to A ratio, again, small e, big A. EE prime ratio, usually normal. Left atrial volume is going to be normal. TR velocity is going to be normal. Grade 2, majority of your grade 2 patients are going to be what we call the pseudo-normal, where the E is bigger than the A. But when you look at your TR velocity, it's going to be greater than 2.8. Left atrial volume going to be greater than 34. And EE prime ratio is going to be greater than 15. So your grade 3 patients is easy because the E to A ratio is greater than 2. Okay? Grade 3, easy. All right? So, and you can revert to your table. Okay? So again, in the table, you have LV relaxation, left atrial pressure, E to A ratio, the average. Well, we use medial, but they have average EE prime ratio, TR velocity. So if your patient is normal, they have no LV relaxation problem, left atrial pressure is normal, EE prime ratio is going to be normal, TR velocity is going to be normal, and left atrial volume is going to be normal. Your grade 1 patient, the E prime is going to be abnormal, and everything else is going to be normals. Okay, your grade 2 so-called pseudo-normal. Okay, you're going to left atrial volume is going to be increased, TR velocity is going to be increased, and they will have a bigger E than the A. Your grade 3 patient is easy because your E to A ratio clinches the diagnosis. It's greater than 2. TR velocity greater than 2.8. LA volume index is increased. And these patients have a problem with compliance. Okay? So try and keep it simple. The things you need to look at is your E to A ratio, EE prime ratio, TR velocity, and left atrial volume. Grade 1 is easy. Small e, big A, everything else is relatively normal. They just have a problem with relaxation, abnormal relaxation. Grade 3, patient relatively easy. Restrictive physiology, the E to A ratio is greater than 2, and they have a elevated filling pressure, so your TR velocity, left atrial volume index, and everything is going to be increased. Your grade 2, your pseudo-normal, the E to A ratio looks normal. The E is a little bit bigger than the A, looks normal. But when you do your E prime is going to be reduced. E to E, E prime ratio is going to be elevated. TR velocity is going to be elevated. And the left atrial volume index is going to be elevated as well. So that is your diastolic dysfunction in a nutshell. And remember, if your patient has significant mitral pathology, you can't use your E prime. Okay? So if they have mitral valve repair, mitral valve replacement, significant mitral stenosis, mitral regurgitation, left bundle branch block, pacemakers, atrial fibrillation, you can't use your E prime.